Welcome everybody. Welcome to the webinar. Today's webinar that is one of the series of ESE talks. The talk of today will be given by Dr. Martine Kool's from Belgium, from Ghent. And she will cover a topic on clinical management of androgen insensitivity before and during transition. And I want to remark, this is a joint webinar from ESE, Endo-ERN and ESPE. I'm glad to chair this talk together with Olaf Hjort from Lübeck. And Olaf, do you want to introduce with a short biography our speaker?
Yes, of course. It's a pleasure to have you all here. First of all, welcome to this joint webinar. And I think, Martine, it's up to you now to satisfy our listeners. It's a very nice presentation on behalf of Endo-ERN, ESPE, and ESE. And we in ESPE know Martine very well. She has been a ESPE young investigator, has been a professor of endocrinology, well known to all of us. And her focus is actually on DSD and also transgender. She has been publishing more than 100 papers on many issues regarding DSD, especially on the cancer management, cancer risk, but also on very clinical aspects as well as aspects of gonadal development. So now you're focusing on a paper that is more in between pediatric and adult endocrinology. I think you will touch all of this gonadal development and cancer risk and give us information on the whereabouts of androgen insensitivity. Currently, Martine is serving on the ESPE scientific committee, so she's in ESPE council, and I think from that point you're also into the management of our societies. Thank you very much that you took on the task of giving this presentation today, and we look forward to hearing your presentation.
Just before the start, Martine, sorry, I recall to everybody that we will have a 15 minutes, 20 minutes time for questions, and there is a Q&A button at the bottom of your page where you can write your question, comments, and we will be glad together with Olaf to ask this to give this question to Martine. Please, Martine, go.
Okay, hello everyone. I hope you can hear me. And thank you, first of all, Luca and Olaf, for this very nice introduction. So this session will be on the clinical management of androgen insensitivity syndrome before and during the transition. Okay, so I have nothing to disclose. And well, as you can see here, androgen insensitivity syndrome is a condition that has many faces. On the left side, you see Caster Semenya. She has partial AIS. She's world record holder on the 800 meters and Olympic champion as well. On the right side, you see Hannah Gaby Odile, who also outed herself as having a complete androgen insensitivity syndrome. She's very famous on the cover of Vogue, Belgian top model, and just like 1 out of 20,000 to 1 out of 100,000 persons, they have androgen insensitivity syndrome, which is an X-linked condition. And in 2/3 of the cases, this is inherited through the mother, who is then an asymptomatic carrier. So in clinical practice, we could meet individuals with AIS as, for example, a 15-year-old girl who's consulting for absence of menses, or a 13-year-old boy, for example, consulting for gynecomastia and lack of penile growth. And what I will cover today is mainly the diagnostic workup, the gonadal management, hormone replacement therapy, and bone health in complete AIS. management of vaginal hypoplasia, management of partial AIS, fertility preservation, and transition, of course. So when you have a very characteristic clinical picture, one could meet these persons as someone with 46XY karyotype, and in phenotypical girls, they could present with amenorrhea, breast development, and scarce pubic hair, bilateral inguinal hernia, gonads in the labioscrotal folds or in the inguinal or abdominal region. And in individuals who have complete AIS, there will be no clitoris hypertrophy, but this can be present in partial AIS. Then there is an absence of a uterus and a short vagina. Phenotypical boys with partial AIS could present as boys who have hypospadias and micropenis at birth with inguinal or scrotal testis most often, and they develop gynecomastia in puberty. And hormonal levels are usually elevated LH and testosterone and a normal FSH. And of course, today we also often have a diagnosis already or a prenatal suspicion, for example, when there is a discrepancy between the karyotype and the baby's phenotype. So in cases where we really right away think about a diagnosis of AIS, it is still very reasonable to do targeted sequencing of the androgen receptor. However, very often we already start right away with a gene panel based on whole exome sequencing. And in general, when the diagnosis is androgen insensitivity syndrome, this genetic approach will confirm a diagnosis of complete AIS in 90% of cases and a diagnosis of partial AIS in about 20% of cases. So this means that there are still quite a number of individuals where you suspect a diagnosis of androgen insensitivity, but you cannot find a mutation in the androgen receptor. And then a very good way to proceed, if you have these available, is to harvest genital skin fibroblasts, which you can then send towards the lab in Kiel of Paul Martin Holterhuis and Nadine Hornig, who have developed a very nice and useful test, an assay to study actually the AR signaling. Because what they do is they expose these genital skin fibroblasts to DHT, and then they measure the upregulation of production of ApoD mRNA. ApoD is a target gene of the androgen receptor, and when DHT activates the androgen receptor, then you see an ApoD upregulation. And this is a group with normal ApoD upregulation, but this is a group of people, or well, genital skin fibroblasts at least, where you don't see any upregulation of this ApoD target gene. And so this group of people, or genital skin fibroblasts, come from people who were suspected to have AIS, but no mutation could be found in the androgen receptor. And interestingly, this group has shown that within the androgen receptor promoter specific of some samples, at least within the promoter, some CpG islands were hypermethylated, and this goes together with a decreased androgen receptor mRNA. And it's very interesting to look further into these cases and to try to find what could be eventually the causing defects. So this could be, for example, a non-coding variant, which could then detect by whole genome sequencing or long-read sequencing. This could lead to identification of mutations in the promoter or in the untranslated region or in intronic regions. And for example, we were able to investigate one of our patients this way together with this group of Nadine Hornig, where we showed that there was a mutation that created an alternative untranslated reading frame. And so this led to normal transcription, but no translation of the androgen receptor gene. So this is one of the possible ways that one could have complete AIS even without finding a mutation in the androgen receptor gene. But very interestingly, this group also is the first one that has shown that also androgen receptor cofactors can cause a phenotype of AIS. They have identified DAM2 as the first identified cofactor, which is required for androgen receptor signaling in an individual who was diagnosed with a partial androgen insensitivity phenotypically. DAM2 is a cytoskeletal regulator, which is important for actin transfer to the nucleus and polymerization. And it is involved in androgen receptor polymerization. So the androgen receptor can only signal when it becomes a polymer and when it is together with polymerase II organized in transcriptional droplets. And this you can see here that this DAM2 groups actually all these molecules together. And if this cannot happen due to mutations, this is for the first time has been associated with partial androgen insensitivity syndrome. So then let's go to the topic of gonadal management. Historically, you all know, of course, that around the years 2000 until 2005, routine prophylactic gonadectomy was actually proposed in all individuals with a DSD, at that time often called intersex, who had a Y chromosome. However, later there was a better insight in the pathobiology of gonadal germ cell cancer development, and this has allowed some risk stratification. For example, you can see here that the bipotential gonad, of course, you know that it has to differentiate either towards a testis or towards an ovary. And many DSD cases result from an incomplete differentiation towards a testis. So when there is no good testicular differentiation, we call this gonadal dysgenesis, which then results in a gonad that presents as undifferentiated gonadal tissue or a very dysgenetic testis or even a streaky gonad. And in general, we know that the germ cell cancer risk in this situation can be very high, whereas the gonadal function is at the same time very low. However, androgen insensitivity syndrome is not a problem of testicular differentiation. It's a problem of hormone action. So once the testis is fully differentiated, it has to produce hormones. And when these cannot be produced very well, or when they cannot act, this will also have an effect on the germ cells that will then undergo a delay in their normal maturational program. In these situations, you see that in general, the cancer risk is relatively low, whereas the gonadal function is much higher and can be very important, for example, in AIS, because then there is a massive production of testosterone. And for women with complete AIS, this is very important because it is converted in the body to estradiol. And so these women can experience spontaneous puberty and they don't need hormone replacement therapy as an adult, for example. And so it's very reasonable, actually, to propose gonadectomy in this group of individuals with high cancer risk and very low gonadal function, but rather proceed with a kind of surveillance program in individuals who have a low cancer risk and a good gonadal function. In 2018, we did a survey among 22 centers to see how they managed actually the gonads in AIS. And the conclusion of this study was that there is a complete lack currently of standardized management. For example, in complete AIS, gonadectomy was still performed before puberty in around 20% of these centers, after puberty in 40%, and 40% did it only on strict indication. And in partial AIS, the situation was even more diverse, with around half of the centers doing gonadectomy on indication, but still some centers doing gonadectomy before puberty as a routine procedure or also after puberty. So many different approaches. And so there is a clear need to better understand the pathobiology and the sequential steps that exist in the development of these tumors. So the primary defect actually is not a defect of the germ cells, but a defect of the environment, which is unsupportive to the germ cells because of the absence or the decreased signaling or presence activity of testosterone. this will result in maturation delay of the germ cells. And this will lead to a prolonged presence of immature primordial germ cells at the center of these tubules, and they express pluripotency genes like OCT3/4, for example, which are important for the survival of these germ cells. And at the same time, there are also germ cells that are stick to the basal membrane and that have already committed to the germline, and they express high amounts of TSPY, which is a gene that is on the Y chromosome and that is related to proliferation of the germ cells. Normally you see that once this TSPY expression starts, the OCT3/4 expression and the primordial germ cells in the lumen of the tubules or in the center of the tubules have disappeared. So in AIS, there is a prolonged period where these two types of germ cells are together, which is called then maturation delay of germ cells. However, the situation becomes a little bit worrisome, evolves towards pre-germ cell neoplasia in situ, when there are of these OCT3/4 positive pluripotent germ cells that make contact with the metal membrane, but they fail to downregulate their pluripotency genes and continue to express together with cells that express TSPY, or sometimes there is co-expression of these markers. So now the cell is equipped actually with increased chances to survive and to proliferate, and this is even enhanced by the defective environment because also their aberrant markers are expressed, and one of the important ones is aberrant expression of KIT ligand. And KIT ligand is a gene that has been related to germ cell cancer development in a typical male population, and it's important for the migration of primordial germ cells very early in embryonic life, but later on it should be downregulated. And if it's still there and influences the germ cells at this stage, it again results in increased survival and proliferation chances. And then this situation may evolve towards germ cell neoplasia in situ with just a small step of polyploidization, which can happen. And then there is the more typical germ cell neoplasia in situ lesion. Excuse me. So the question is, how often does this actually occur? Because you can see here typical testis development, but with an androgen receptor defect. What we most often see is that most of the tubules do not contain any germ cells at all. And there are some islands where some germ cells may remain and express TSPY as I see here, but they may be very rare. And when the patient gets older, actually, increasingly these germ cells disappear. If we do a meta-analysis of the literature and we look only at individuals who had gonadectomy post-puberty, currently, around 2021, around 456 of these cases had been published, and pre-germ cell neoplasia in situ, or the more full-blown lesion, was identified in 6.4%. Invasive germ cell cancer was more rare, was only seen in 1.3%, all in adult women, not in children or even not in adolescents. And in men with partial AIS, 26 cases were published, and there were no persons with reports of a germ cell neoplasia in situ or an invasive tumor. So overall, it's not a very frequent event. We did an additional study looking at 52 persons with genetically confirmed AIS, had gonadectomy post-puberty. 42 were complete AIS women, and 10 were individuals who had partial AIS. In total, 97 gonadal samples, and we did not only look at histology, but also at the presence of risk alleles that had been related to gonadal germ cell cancer development in the general population. Usually this is done through genome-wide association studies, where you identify specific genes that are associated with the development of this cancer if you have a specific risk allele. So the results of our study were that there were no germ cell neoplasia in situ or invasive gonadal germ cell cancer. And these pre-germ cell neoplasia in situ lesions with co-expression of OCT and TSPY at the basal membrane, they were found in 14% of women with complete AIS and in 1 out of 10 persons with partial AIS. and we looked at these risk genes, then we could see that there were two of these SNPs that were of relevance, apparently from our study, which were KIT ligand and a gene that we don't know very well, ATF7IP. Where you can see here that all the individuals who had this pre-germ cell neoplasia in situ were homozygous for the risk allele, but also several other individuals who did not have any germ cell neoplasia in situ. So there, from you can see that it's not really a good way to discriminate between the ones who will and who will not develop these germ cell cancers. We also made a kind of risk score based on all the presence of all these risk alleles, and there was a higher score for those with the pre-germ cell NIS, but in the end, again, huge overlap between the two groups. So in conclusion, we cannot really take this as a further approach to discriminate and identify those individuals who really need gonadectomy. But overall, looking at these prevalence of invasive gonadal germ cell cancer, and also taking into account that gonadectomy is associated with a negative effect on quality of life, we'll come back to that later on, it is not reasonable to propose routine gonadectomy as a first-line approach. And so it's much more reasonable probably to discuss careful surveillance as a possible alternative. Of course, we need to mention to our patients the important limitations of imaging and of serum biomarkers. We need to listen to what are the individual preferences. For partial AIS in boys, the situation is different because there you have the gonads that are in a scrotal position, which can be visualized very easily with ultrasound. And you can also palpate these gonads. So there, a protocol with annual ultrasounds and also a biopsy at the end of puberty, where you will specifically look at the presence of this germ cell neoplasia in situ, is probably a very good approach. So in total, one could say that a shared decision-making with the young adult is currently a very good approach, and this has also been transformed to these more looking a little bit complex guidelines. But if you look at the paper, this paper here, you will find step by step how to come to this decision tree. Of course, as I said, we need to discuss the limitations also of the surveillance possibilities. For example, there is one study that dates back already from 2013, where 13 women with complete AIS went to the operation theater, but before that they had an MRI. And at the pathology assessment, in 3 of these germ cell neoplasia in situ was found. However, on the MRI, it was not able to detect any of these 3 lesions. So MRI is very good in detecting benign lesions. It's very good to find intra-abdominal gonads, which is not even very often not possible by ultrasound, but it will not be able to detect the germ cell neoplasia in situ, although we can detect an early more progressive cancer with it. There is also the possibility to use serum and semen markers, the classical ones, alpha-fetoprotein, beta-ECG, but they have actually very low sensitivity, especially for seminomas. And these are the type of tumors that we then expect to see in AIS. But a lot of hope have been put on the presence of microRNAs, specific microRNAs that are secreted by all the type 2 gonadal germ cell cancers, which is the type that we are talking about. They also have biological significance, as they are inhibitors of the p53 tumor suppressor pathway. And it has been shown that they are very reliable to detect invasive tumors and to use it after you had a tumor and after you had gonadectomy to see if there is relapse of the condition. But it's not, they are not secreted actually by germ cell neoplasia in situ. So unfortunately, this is also not a good biomarker biomarker to detect these pre-invasive lesions. But the way we do it in our clinic, at least, is that we do an annual MRI and annual blood sampling for these tumor markers, and we explain very well if the patient, of course, decides for this approach and not for the gonadectomy. But in our experience, all the young girls that we discuss this approach with, they all choose this approach rather than having gonadectomy. Let's then move on to hormone replacement therapy in women who have complete AIS. Of course, you only need this following gonadectomy, because in women with complete AIS, there will be high levels of testosterone, and that will be converted by aromatase to estradiol. So no gonadectomy means that you don't need hormone replacement therapy. The aims of the therapy are to maintain female secondary sex characteristics, prevent bone loss, prevent neurocognitive disorders, promote cardiovascular health, just like always in HRT. There are no standardized dosing schemes specifically for this patient population, and it's reasonable to follow general guidelines, like, for example, micronized oral estradiol 2 to 4 milligrams or transdermal estradiol. Of course, you don't need to add progestins because there is no uterus. And it's important to notice that many women who had first endogenous testosterone production, but then gonadectomy, they perceive the HRT as suboptimal compared to their previous testosterone production. It results in fatigue, hot flashes, and mood swings, and a decrease in sexual functioning and psychological well-being in many women. So it's very reasonable to ask the question whether perhaps supplementation with testosterone would be better as an approach in women who have complete AIS. And our co-chair, Olaf Hjort, has done a very elegant study to address this question. And this is a study, a double-blind, placebo-controlled crossover trial with transdermal gel of estradiol and testosterone, and then after 6 months, the other way around. And in this study, the primary outcome measure was mental health-related quality of life, and secondary outcome measures, psychological well-being, sexual function, and somatic effects. Actually, all the outcomes were similar, except for sexual desire, where testosterone really outperformed the estradiol. So at least one can conclude from this study that testosterone is a safe alternative for estradiol, and perhaps it is preferred in women with a reduced sexual functioning. But of course, in this study, it was not possible to investigate on the longer term the effects on bone mineralization, body composition, metabolic profile, and so on. So this requires further study. With regard to bone health in AIS, there are also quite limited and poor quality data on bone health in adult women who have complete AIS following gonadectomy, and very few or perhaps no data on bone health in adult women who did not have gonadectomy. There are also very few data on the other peripheral testosterone-mediated effects, like on body composition, metabolic profile, immune regulation, cardiovascular health, and so on. So there is certainly an area for further research here to be done. And thinking about these effects on bone, one should realize that there are dual effects of testosterone and estradiol on bone. Testosterone stimulates bone mineralization. Estradiol stimulates trabecular bone formation, and it limits endocortical expansion. That's how women have a good bone cortex, actually. And for men, it's different because testosterone mainly stimulates the periosteal expansion. And both estradiol and testosterone inhibit bone resorption. So overall, combined effects of testosterone and estradiol on bone, but the effects of estradiol and IGF-1 have been found to be more important probably than of testosterone. Nonetheless, there is one, I think, very good study, large enough study, also with a control group on 32 women with complete AIS. Mean age was 34 years. They had a gonadectomy at a mean age of 12, and they were all on hormone replacement therapy. 2 milligrams or transdermal estradiol. And remarkably, in this group, over 50% had osteopenia or even osteoporosis. And the trabecular bone, which you can see here, seems to be more affected than the cortical bone at the femoral neck, for example. And giving the hormone replacement therapy, transdermal estradiol, seemed to be better in improving a little bit the bone health as compared to the oral estradiol, especially at the lumbar spine. One could ask the question whether it's not needed to give perhaps higher doses of estradiol, as perhaps, and we also know this from other populations, 2 milligrams is often very little actually to reach the typical female ranges of serum estradiol. Then let's move on to the topic of vaginal hypoplasia, which is, of course, also a major concern for individuals who have a diagnosis of AIS. Actually, vaginal dilation therapy has nowadays become the first-line choice because it has a much better functional outcome than surgery. One should note, though, that many girls experience sexual intimacy prior to therapy. So very often there is some pressure from us, from the doctors, or also from the parents, for example, that they need to start with this therapy just to be ready for the moment that they perhaps have a boyfriend. But it's important that the motivation should come from the girl itself. The intrinsic motivation is one of the key factors of success of this treatment. So it makes absolutely no sense to push these girls for this therapy at the moment that they are not ready for it. We and also others have shown that you have much better outcomes if you can have this therapy supported by a psychologist and by a pelvic floor physiotherapist who can really practice hands-on training with the girls. This will lead to better outcomes. And most of them, over 90%, will reach a vagina of over 7 centimeters in a period of 3 to 12 months. And with which they can have pleasant intercourse. And apparently, it's important to dilate several times a day. This can give much more rapid success. For example, if you dilate once 30 minutes, then you have less effect than if you dilate 3 times a day for 10 minutes. So the best moment to start is when you're really most ready and motivated. And in our experience, we have very poor results in girls who are below 60 years of age. So usually we will add this as a criterion to start. Also, a question is, do you need maintenance dilation when you have no ongoing relationship at that time? And based on the findings from research, it appears to be only needed when you do a vaginal dilation after surgery, because then there is a risk of stenosis, but not as a primary therapy. Alternatives for this are, of course, the regular coitus, which is also a very good way of reaching a good vaginal length if you have a comprehensive partner. Or there is a kind of procedure which is called the Vecchietti procedure, which can also be an alternative, which is a kind of very rapidly forced dilation under analgesia, which can be done sometimes in specialized centers. I would like to refer you to the website of DSD Families for a very, very good brochure for teenagers that has been developed on vaginal dilation to explain this to your patients. And this can be very helpful. It's really at the level of teenagers, very nice material. So a few words about partial AIS. This is a situation where the sex of choosing or determining the sex of rearing is very difficult, especially when there is a relatively low external genitalia or external masculinization score. And there is no right or wrong actually in this situation. So the most important is to do no irreversible things and to listen to the growing child and adolescent to see what is the final gender identity that develops. We have some remaining questions in girls who have nowadays retained gonads, which is a relatively new situation because previously we always did gonadectomy at a young age. But now girls grow up with these gonads in situ, and if the gender identity is female, we actually don't know very well what is the impact of living with atypical genitalia and with labial testes on the development, and to what extent these girls will virilize during puberty, and if gonadectomy is always needed to avoid virilization, if we need to push the girl to do gonadectomy before puberty. So probably the best approach is to wait and see, let's say, and probably perhaps Olaf or other people have experience with this situation, but I think overall this is currently a relatively new situation. For boys with partial AIS, a typical complaint is that they have poor penile growth, and almost all have quite important gynecomastia, irrespective of the virilization at birth. And this can be really of high psychological impact, and they almost all require a mastectomy. So the hormonal levels are really as we would expect, with elevated LH and testosterone and estradiol, but a normal FSH. Typically, they've had more complex hypospadias surgery and a higher need for multiple re-interventions. Probably this is due to reduced tissue healing because of a lack of AR signaling sufficiently. Fatherhood has been described in partial AIS, and sometimes, especially when there's, for example, no hypospadias, then this is called not partial AIS, but minimal AIS, and then it's called MICE, which is another kind of abbreviation. In PIES, it's very, very rare, and sometimes possible also through ESE technologies. With regard to hormone replacement, one could argue that if you give a lot of testosterone extra, then maybe you could overcome the defects. And this then is preferably done by DHT, which is non-aromatizable, so will not be converted into estradiol, but it's not available in many countries. Personally, I have some experience with using an aromatase inhibitor, which was very, very effective in avoiding the development of gynecomastia. But if you give this medication in an adolescent, 12, 13 years old, for many, many years, you start to wonder, how long should I give this? Are there any side effects, or will they be in the future? What is the effect on gonadal germ cell cancer risk, and so on? So I think this is a very difficult situation, and the number of patients is so small that it will be very, very difficult to reach data on safety and on outcome of this approach. Then I would like to say something about fertility preservation, but first of all, I would introduce to you Jo Williams, who is a woman living with complete AIS, and she will explain a little bit about infertility and what this does to her. I'm not sure if it will work.
Hi, my name is Jo Williams, and I'm a 48-year-old woman with complete androgen insensitivity syndrome. And I was asked to answer a couple of questions about my thoughts and experiences of having AIS. Okay, so the first question: what has been the most difficult thing for you as a teenager and as an adult woman living with AIS? So as a teenager, I was still not aware that I had AIS, as this information was only shared with me when I was in my 20s. So for me, probably the most difficult thing was the lack of accurate information about my body. And instead of full truth disclosure, I was given little pieces of information that never seemed to build up to a whole picture. For example, I was told by my family doctor that I might need to have surgery before being able to have sex, but then was just not given any more information about this, which made it really difficult for me to feel comfortable or confident in just having relationships. After finally being given all the information that I needed, I have subsequently gone on to have good relationships and have been with my current partner for over 20 years. But probably the most difficult thing as an adult was infertility. When I was told as a teenager that I couldn't have children, I was upset, but this was still very much an abstract idea. And even in my 20s, most of my friends were more focused on going out or work, and I was just going along doing exactly the same things as they were. However, when I reached my 30s, it felt like everyone I knew was suddenly pregnant at the same time. And I found this really difficult and just really isolating. And it was probably the time when I was most acutely aware of my differences. And as everyone I knew was now pregnant, I felt like I'd lost a lot of that peer support that I had relied on until then. And it felt like everyone was moving on to do something that I wasn't able to do. So I've subsequently gone on to adopt, and this has been incredibly rewarding, and my life is good. But I would always stress that infertility can be really challenging and really lonely, and it may only really hit you when you're in your 30s.
Okay, so thank you very much, Jo, for sharing this with us. And so, as we just heard, infertility is a very important burden for many individuals with AIS. Offspring spontaneously or by assisted reproduction is very rare. And of course, when we now postpone gonadectomy towards adulthood, this is at odds with fertility chances because of the progressive loss of the germ cells that we have heard of. And current options, actually, testicular semen extraction is not really an option for individuals with AIS because this requires mature sperm, which is almost invariably not the case in AIS. So this leaves us with the possibility of testicular tissue cryopreservation, which can then be used for in vitro maturation of germ cells, for spermatogonial stem cell transplantation, or autografting of testicular tissue. And although this latter approach seems to be the most feasible, there are very limited indications because only for non-malignant conditions. So this hampers a little bit the research on this option. And unfortunately, all the experiments and all the techniques that have currently been tried with human immature testicular tissue have all resulted in massive loss of spermatogonia and do not really result in spermatogenesis. So currently, there are limited or no fertility options for individuals who have AIS. And in addition, I would like to add some additional thoughts to that. For example, if there are germ cells that are still left, these are usually pathobiological germ cells. One could ask the question, why do these germ cells survive, whereas all the other germ cells have been, for example, removed by apoptosis? Do we really want to use these germ cells for fertility preservation? And so, in addition, for complete and partial AIS for women who have this condition, there will be an additional need for a female partner or donor egg or gestational carrier. So many hurdles, I think, and challenges before the problem of fertility can be solved. Then let's move on to transition. Transition, we think about transition as something that acutely happens around, between 16 and 18 years old. But actually, this is a very, very long and gradual process that in the eyes of the pediatrician already starts in early childhood. For all the SD conditions, there is so much information to be shared at every single stage in life, already starting from the age of 4 years, 6 years, and onwards. And increasingly, the information that you give will be provided to the affected individual. And so we actually prepare for this moment of formal transition already for a very long time. And that's why we can actually see this transition clinic as really the cherry on the cake, which is a crucial event in the medical history of many adolescents. Usually we do this transition clinic with many people together, of course, the patient, but also pediatric and adult endocrinologists, the psychologist, the gynecologist, and if available, if vaginal dilation therapy is needed, for example, pelvic floor physiotherapists. A good transition clinic, I'm really convinced that it can greatly influence the long-term outcome of our patients. It's a very good moment for information, for decision-making, although, of course, information has already been passed for a very long time. But sometimes the adolescent may have forgotten all this information or may just now be able to understand all this information. You can take some time to discuss all the pros and cons of the different treatment options. And in the end, the adolescent is really equipped with a very good overview of everything that is needed and has time to consider all the options. And importantly, the DSD Live study has shown that transparency and openness, so really discussing all the various possibilities, these are the factors that have been associated most with positive mental health outcomes. And it's also a moment, I think, of mutual learning. I think transition is fun to do because you are together with a colleague that usually you're not working together with on a short distance. It's a learning moment for the adult endocrinologists, I think, especially with the focus that we have now on patient autonomy and the choices that need to be made in adulthood. The adult endocrinologists are facing clinical questions that they are maybe not so familiar with, because earlier on, all the girls had already gonadectomy, and now they need to discuss this possibility of gonadal surveillance and also vaginal substitution, and not the vaginoplasty procedure that used to be done in earlier days at an earlier age. For us as pediatricians, it's also very interesting because adult endocrinologists may use formulations that we are not very familiar with, and each of us talk about specific topics, and it's nice to have this mutual learning. But we can also learn a lot from patients, and again, Jo will tell us something about her life and experiences with AIS. Oops, I don't know if it will work. Try again.
So the second question I was asked to answer is, where do you think most efforts in research on AIS should go to? One of the things I would really love to see would be more effort going towards researching the impact on families and the need for psychological and family support. I think having a child with any difference can be really challenging. And if parents are really struggling, it makes it really difficult for them to be the best advocates for their children. And I think if you're able to help parents just to know that having AIS isn't a catastrophe and it's not something that needs to be a secret or shameful, they are far more likely to be in a position to be open and honest with their children and just have the language to be able to share age-appropriate information with them. And finally, the last question, it's what have you missed most in your relationship with your doctor, and what advice would you give to doctors about how they can help you best? I would say that if you are a doctor working within a specialist AIS or DSD clinic, I think one of the most helpful things you can do is to provide opportunities for peer support. I often see doctors saying, oh, well, we refer to support groups or to charities, but sometimes these support groups or charities don't even exist anymore. And a good example of that in the UK is the AIS support group, which was very active 10 years ago, but not so much currently. So I think if doctors or clinics are able to give those opportunities to either have a family day or to have days where adult patients are able to meet, just so that people can just normalise the experiences they have and just give opportunities to meet other people that have experienced similar things. I think this can be especially helpful for children, because I think when parents are then trying to share the information with them, they're able to say to the child, oh, you remember this person you met there? Then they have AIS the same as you. And it's something that can be really normalising and just allow children to have those relationships as they're growing up. Anyway, I hope some of this was helpful, and thank you for asking me to answer the questions. Okay, bye.
Okay. So, of course, there are a lot of transition readiness questionnaires which you can use. Just have a quick search and you will find plenty of them. We do it in practice as 1 or 2 joint consultations with the adult colleagues, and provide a written summary to the adult colleague and also to our patients. And just as some take-home messages, I think the key learning points today were that AIS may result from loss of signaling to the androgen receptor, not only from mutations in the androgen receptor. Gonadectomy is not indicated in childhood and should be the subject of shared decision-making in adults, and careful surveillance can be a very good alternative. Vaginal dilation therapy is a first-line treatment for vaginal hyperplasia. Infertility is a major burden for individuals who have AIS. Patients want to be early and fully informed. Peer support can be very powerful, as also demonstrated in this example. These were some individuals with DSD. Many of them had AIS, and together they developed a theater play, and they traveled through Belgium and the Netherlands for over a year, I think, and the play was very successful. It was about their life as individuals with a DSD condition. And transition is very important for both a patient and the healthcare provider. However, we do have a lot of remaining questions, like will there be some periodization of girls with severe partial AIS in puberty? What is the optimal treatment for boys with partial AIS and the place of aromatase inhibitors? How could the surveillance of retained gonads be optimally organized? And what is the functional outcome of retained gonads on the longer term? Will they continue to produce testosterone, or will they become fibrotic and sclerotic over time, as we have some arguments for in some individuals? So with this, I would like to leave you and thank you very much for being here. And perhaps you have questions, and I'm ready to take them. Thank you.
Thank you, Martin, for the very nice talk.
Yes, thank you very much also from my side. You have some excellent questions here, and the last one is maybe the nicest because it just says excellent lecture. Thank you so much. So that's a good one, but we also have some questions that are, let's say, to the point, and I would summarize one part with the biochemical screening in patients with AIS. So what's the experience with the use of tumor markers in the flow chart that you showed? I mean, the experience of how often have you picked up higher values of beta HCG and alpha fetoprotein, or what's the use of inhibin B, for instance, in Sertoli cell adenoma? Would you give a recommendation to all?
Well, fortunately, I should say we have never picked up any increased levels of beta HCG or alpha fetoprotein. We also never picked up a tumor, actually, so far. Overall, it's very well known, actually, that these are not good and unreliable tumor markers. So usually, we do it because we do some blood sampling anyway, but I would not even do a blood sampling specifically for these tumor markers. I think the MRI is then even a better alternative than the tumor markers. In addition, that study that I mentioned was from 2013, and I think the resolution of MRI has, of course, much progressed, I think, in that time, and perhaps it's a good moment to do this kind of study again, I think, and see what is now possible with MRI.
Sorry, but in clinical practice, so I understand you discuss with the family and the patient how to go for gonadectomy or follow up and up to let's say the adult age, but then how you follow the risk of tumorigenesis. You mentioned that you didn't find any positive tumor markers. Then how do you do it practically?
Well, for girls with complete AIS, we do annual MRI, and we really try to make sure that this is also done. So, of course, all the girls, they say, yeah, sure, I will come every year, and in the end, it's a bit doubtful whether they will really show up every year. But we really try to emphasize this and also call them if they don't show up. And for boys with partial AIS and retained gonads, we do an annual ultrasound, and I would propose a biopsy at the end of puberty. Of course, we could also propose a biopsy in girls if there is some doubt based on the MRI, or if something can be seen there. We would also do a biopsy, but of course, there the gonads are usually in the abdominal position. And so this requires really anesthesia. And,
only imaging, not biochemistry.
We do biochemistry because we do a blood sampling at that time to check for the estradiol levels. And then, yeah, okay, we also check the boxes of the tumor markers. But I don't even think the value of these tumor markers is sufficient to, to justify it gives you a false feeling of safety, I think.
Okay.
What about inhibin B to detect the Sertoli cell adenomas? Because I think we have seen them more frequently. We see the rising inhibin B. Do you recommend gonadectomy at that time? It's a difficult.
I must say that I don't check inhibin B, but I agree that it could be for this condition, it could be good to do that. Would you do for a Sertoli cell adenoma a gonadectomy? I don't know.
One is unsure because the imaging then looks difficult. So there is a tumor in the imaging, and you don't know what it is. So then you have to do something.
I think we would do a biopsy then at that time. If we would see something on the MRI, we would do a biopsy. But I agree that inhibin B is a good thing to do as well.
There's a second question regarding the estradiol, and what about screening for breast cancer or other tumors, and how do you monitor the estradiol? Do you just monitor the estradiol levels, or do you also look into LH and FSH, or also after gonadectomy?
Well, personally, I have very little experience with adult women who had gonadectomy, and so I didn't monitor anything at all in these persons. My adult colleague. Well, let's come to the question of breast cancer. I think, and I discussed this with our gynecologist, this follows the same guidance as for the general female population. And we had once a girl who had a genetic predisposition for breast cancer, and she was sent to the sonography and so on to the same extent as her other family members.
I found that question interesting because, as some people might remember, coming from ESPE meeting in Den Haag, Johan Hughes proposed that maybe AIS women wouldn't get breast cancer, but I think there is some experience, or at least word that by the self-help groups that breast cancer can occur in AIS. Maybe rarer due to the lack of progestins, but you never know. Okay, so there is a question again from somebody. Sorry, I have to look. For women with CIS, do you continue HRT until they come to the usual age of menopause? I mean, that's a question again for an adult endocrinologist, and I wouldn't know how to answer it. Maybe you do, but anybody else has an answer? How long we should do a replacement therapy?
I think replacement therapy should be prolonged up to the age of physiological, at least to the age of physiological menopause, and screen for the risk of, as in normal women, 46 women. Yeah.
And would you, at that, before you decide to stop, would you do, for example, a bone densitometry and advise to take it a little bit longer, maybe if the...
Yes, sure. And maybe you can anticipate also the mineralometry, because you may have some concerns about the bone mineralization in this kind of individuals. Yes.
Our adult endocrinologist recommends a regular bone scan from the age
Yeah.
of 40 onward. So
Yeah.
if young women of 25 to 40, she says they might skip it because they are not at high risk. But is there any other recommendation in the adult community? Luca, maybe you better off to answer.
No, as I mentioned, yes. What we usually do is to follow up the bone scans. You mentioned 40 years and beyond 40 years, but yeah, generally about even earlier we do it. A scan, and then we decide how to follow afterwards.
Yeah, I think in AIS I would do it more frequently, and not only from 40 years onwards, because we have this lack of testosterone effect as well, and hormone replacement therapy. So we do it actually from the moment of transition, and then according to recommendations, if everything is fine, then every 5 years or so, and if it's very poor, then we could consider it.
Try to pick up the peak bone mass and then follow.
Mm-hmm.
Heidi Klaassen asked the question if there's any experience with fertility preservation in CIS and gonads in situ. I mean, has anybody done anything with that? We haven't, so.
I don't know.
No.
I don't have.
I know there is a paper from Finlayson from, I think, the US, and they they did a very kind of basic approach where they they counted the number of germ cells that were present in gonadectomized material, and from there they concluded like, oh, there's many samples that do have some germ cells, so shouldn't we invest in preservation technologies? But I think that's the only attempt that there has been so far.
May I ask one question? Because I remember a patient that was referred to us for a possible LH secreting tumor, and it revealed with gynecomastia, and it revealed in our hands to have to be a mild androgen insensitivity syndrome, and we didn't. He was already. He had an appointment with the neurosurgeon to remove the pituitary adenoma, but we think this was not the case after the diagnosis that we made, and we are now following him, and I think this is an hyperplasia, pituitary hyperplasia, may related to the fact that he has this kind of situation, the lack of an adequate feedback. So, do you have any experience on the because this was is a rather young person. He is already father twice or thrice. Yes, he's mice, so he has normal male.
I don't have experience.
Masculinization, but he has these elevated levels of LH, and
But then I wonder. I'm not aware of studies that have imaged the pituitary in all kind of hypergonadotropic hypogonadism conditions, but one would wonder that in all these cases, in all these conditions, there could be the same finding. And I don't think there is anyone has done this or found this. So I would expect it to be a little bit more frequent, and I don't know. Do you have an experience, Olaf?
No. And I have one more question where I also have no experience. There's one question regarding the long-term risk of cardiovascular disease. So do we know anything? I think we really need the registry work together with ESE and Endo-ERN and ESPE to really calculate what the risk management of overall health problems in AIS would be. maybe you have a different answer to that one.
I have been looking for this while preparing this talk, and I couldn't find anything.
No.
Yeah, I should mention that we have a survey that will be soon run among all the HCPs of MTG7 within Endo-ERN that deals on the management of AIS and to find the differences in the management. So this maybe will answer some of the questions that we received here on the state of the art, at least among the Endo-ERN centers.
Yes, I think that was a very good word, Luca, and I think we need to survey, especially the adult patients. At least Martina and I are looking only after the younger people, and we need the answers of the adult community for this, maybe. I don't see any further questions, and it's 18:05, so I think we have done brilliantly in time, and I think we should thank Martine for a wonderful presentation. There were quite a lot of people in the audience, and very good questions here. So maybe I can close the session together with Luca and saying that thank you very much for joining us. Thank you for Martine again for giving this talk. And you see now on the screen quite a lot of programs that will come in the near future. You want to say the last word, Luca, please?
Oh, no, it was a remarkable lecture, and we hope you see here the various activities of ESE reported here. We will have new programs for ESE talks in the new year. We still don't know the schedule, but there will be other ones like the ones that we had here today. And you can see there is a joint congress of ESPE and ESE that is scheduled for 2025. This will be maybe the opportunity to discuss these issues together among us, pediatric and adult endocrinologists, on the long-term management of this kind of diseases. So that's all, and have a nice evening, and bye-bye.
Okay, bye-bye to everyone.
Thank you, Martin.
Thank you.
Bye.
Take care.